We've got some people online and some people in the room here in Toronto at the Elixir Cancer Rehabilitation Survivorship Centre at Princess Margaret. My name is Dr. Jackie Bender, and I'm actually going to be the moderator and presenter today. Dr. Jennifer Jones has a conflict, so she will not be moderating today. So I'd like to welcome everyone to this month's rounds, and of course those who've joined remotely. So the format is that in this case I'll actually be introducing myself, and then I'll speak for probably about 35-40 minutes, and then open it up to discussion. While I am presenting today, I'm actually the co-PI for this project along with my collaborator and the other co-PI, Dr. Arminee Kazanjian, and unfortunately she's not able to attend today, but you sent her regrets. So I'll introduce myself. Again, I'm Dr. Jackie Bender, and I am a scientist here at in the Department of Supportive Care at Elixir at the Princess Margaret Cancer Centre, where my program research focuses on digital health, cancer survivorship, and implementation science. I design, implement, and evaluate ways to improve the health of cancer survivors and their family members through patient-oriented essentially digital social health interventions. And my collaborator and co-PI, Dr. Arminee Kazanjian, is a professor at the School of Population and Public Health at the University of British Columbia. She is a well-recognized health services researcher with extensive experience in health technology assessment, navigation, supportive care, and survivorship, and does a fair amount of population-based public health research. So now it's a bit odd introducing myself. I'm going to go on and start the presentation. I'm super pleased to be here today to tell you about an innovative peer support navigation program that we've developed and launched in Toronto and Vancouver. This work was awarded by Prostate Cancer Canada and proudly funded by Movember. It's part of the TrueNTH suite of solutions funded by the Movember Foundation. So what is TrueNTH? TrueNTH is a global plan to improve prostate cancer care through an innovative series of survivorship interventions that essentially aim to improve access to quality of life enhancing information, improve access to care and support, including treatment information as well as lifestyle advice to facilitate and improve access to peer support and experiences shared amongst other prostate cancer survivors, and of course their access to healthcare professionals. TrueNTH is a global initiative, and Movember has invested over 40 million Australian to date across the network that includes Australia, New Zealand, United Kingdom, Ireland, Canada, and the USA, involving over 300 researchers, clinicians, working in partnership with patients and family members. And the overall goal of these TrueNTH projects is really to enable men and their families to achieve a good quality of life and feel knowledgeable and confident about managing their disease. There are a series of program themes and project themes that TrueNTH aspires to address, including focusing on, with respect to program themes, evaluation and health economics, IT enablement, and social and practical support. And with respect to the extending into the project themes, really focusing on navigation and care planning, self-management, post-treatment follow-up, education and decision support, symptom management support, psychosocial support, sexual health, and lifestyle management. And these core themes were identified, really driven by patient-identified and family-identified needs and priorities in order to improve the life of men with prostate cancer and their caregivers. So today we will be talking about the TrueNTH Care Navigation Intervention. Ours is one of the few interventions that is specifically focused on increasing access to peer support, and through that sort of peer support, enabling improved navigation through the healthcare system. This is a screenshot of our homepage to our program website, where patients and caregivers can access and get matched up with a peer navigator, and where peer navigators also can apply to become part of the program. Before I go much further, I did want to recognize the entire team. We've got a super core team led by myself and Dr. Kazanjian, along with Dr. Andrew Matthew, a psychologist also running one of the TrueNTH interventions, these Share C interventions, sexual health interventions. Dr. Winston Isaac, who is our patient representative, Rupert Casaban, who's our caregiver representative. Dr. Shima Sahalipour is the project manager, overall national project manager. Dr. Faminder Flora, who is a scientific associate on the team. Mihaela Derlia, who's a registered social worker research coordinator on the team. Yuni Hakoban, who's the physician and research coordinator in BC. Our industry partners are Healthcare Human Factors is the design firm, NextJ is the software development firm, and host vendor, and we've got a fabulous set of clinical collaborators at Princess Margaret in Vancouver, where we're deploying the intervention. Here at Princess Margaret, Dr. Tony Finelli, Dr. Charles Catton leading the clinical championing of this, along with Leah Jamnicki, who is the GU nurse coordinator, and Megan Wexler, who's social worker and the lead of a volunteer program here in our second pilot site at BCCA, Surrey, Fraser Valley, as well as Vancouver, led by Dr. Winkle Kwan, Dr. Meyer Keys, as well as the TC Prostate Cancer Center at Vancouver General Hospital through Phil Paula. And lastly, but not leastly at all, and most importantly, is our community partners through the Prostate Cancer Care Network, the Toronto Support Group, and the Vancouver Support Group. So thanks to everyone for everyone's involvement. I'm actually noticing that this slide does not include previous team members who've moved on to career advancement, as well as students. So I did want to acknowledge them as well. So the rationale. Why focus on improving access to peer support and navigation through the health system? Well known, in fact, a national report really highlighted, a national report by the Canadian Partnership Against Cancer highlighted that Canadian men with prostate cancer and their caregivers actually lack access to adequate information and support, and particular emotional support, and experience gaps in care. National registry-based survey that we conducted in 4 provinces really identified and confirmed the lack of the unmet supported care needs that this group has, particularly in these domains. Working with patients and caregivers in workshopping and networking funded and supported by November, as well as this national registry-based survey that we conducted in collaboration with Deb Teltman-Stewart and her team, we identified that the #1 solution to addressing this lack of information and emotional support for men with prostate cancer is a navigator. Evidence suggests, I'm going to pop these all up, it's easier for me. Evidence suggests that peer navigation programs are quite effective in addressing these gaps or deficiencies in information and emotional support and improving navigation through the health system. Particularly timeliness of care. There are many models, and these models date back to really the mid-1990s when they were first introducing cancer amongst women with breast cancer to address access deficiencies in areas in Harlem. Those results of those studies found that navigation is a really effective mechanism to increase timeliness of care and address these mechanisms. As I was saying, many different models have emerged since then. Some are professionally led, often by nurses or social workers. Some are peer-led. Some are facilitated online. Some are self-led. And through an environmental scan and review of literature, we found that most patient navigation programs are professionally led by nurses. There's actually only one peer-led program for PC in Canada that we're aware of, and none target caregivers. And interestingly, some of the most valued aspects of patient navigation are assistance in addressing information needs, assistance in addressing emotional support or lack of emotional support, buffer against loneliness, constant sort of companion and source of support, and logistical coordination of care, a lot of which points to a social support-led model of peer support. And interestingly, for men with prostate cancer, the most valued form of support that was identified from a systematic review of the literature on needs and preferred sources of supportive care was, in fact, support from a peer cancer survivor. Web-based methods can improve access, enhance access to peer support and navigation, and we know from our national survey that at least 65% of Canadian men with prostate cancer want to receive health information support via the internet. So all of that led us to proposing and developing the TrueNTH peer navigation solution. The TrueNTH peer navigation solution, the overall goal essentially is to improve the health outcomes of men with prostate cancer and their partners through access to a trained peer navigator. So what we mean by peer navigator is either a prostate cancer survivor, someone who's experienced and or been treated for prostate cancer, or a caregiver, family member, partner, spouse of a man who's had a prostate cancer, who has been trained, and that's a really critical part to be a peer navigator. What we've learned from the reviews of literature is one of the critical success factors is training to be an effective peer navigator, effective navigator in general. And our overall theory of change is that through these peer navigators who will assist men and or their caregivers as they navigate and go through the prostate cancer journey, by providing that practical, informational, emotional support, which some people often call high, that is helpful in improving perceived social support, feeling supported, helpful in reducing distress, improving their likelihood and ability to access services, and engaging in self-management. And by helping others, peer navigators are expected to experience psychosocial benefits themselves, such as that helper's high and that increase in self-esteem and other psychosocial benefits. So our program, being patient-driven and through a patient-identified need as well, is also grounded in well-known theories of social support as well as technology adoption. The theoretical underpinnings with respect to social support really draw from stress and coping theory, which suggests that social support from peers can promote coping efforts, which lessen negative appraisals of events and bolster coping efforts and in turn reduce anxiety. Social comparison theory, which suggests that in times of stress, we look to others who've experienced that particular situation in order to judge and normalize our feelings and experiences. Optimal matching theory, which suggests that social support is really only effective if it matches the demands and the nature of the stressor, as well as the preferences of the support provider, the support seeker. Selfefficacy theory, which suggests that social support from peers can enhance one's confidence in engaging in specific activities despite obstacles and performing those self-management behaviors. And then lastly, helper therapy principle, which suggests that when a helper provides assistance to others, that they actually benefit themselves. And some feel that that benefit can oftentimes be greater than that which is experienced by the individual who is receiving the support. So with all of that theoretical basis and grounding, we set off to conduct a very rigorous design and development procedure to build this intervention. And we really were grounded in patient-oriented research and user-centered design principles to build this program. And so that involved 5 core phases, the first being an environmental scan and systematic review, which I spoke about. The second phase being a population-based survey that involved 4 provinces that was conducted in collaboration with Deb Sullivan Stewart and her team, which confirm the need and desire for a navigator. And we conducted a qualitative study with patients, healthcare providers, and caregivers in Toronto and Vancouver to understand men's and caregivers' needs and expectations for navigation. What were the sort of characteristics of an effective peer navigator, and what were the overall sort of expectations that one would, with regard to what one would receive and gain from that? that then informed the user-centered design and development of the two core program components, which is the training program and then the web-based portal that acts as a means to connect patients and care navigators and supports their communication and exchange of support. And then phase 4 was the recruitment and training of care navigators. That's really what I'm going to focus on today. And then lastly, the pilot feasibility of the overall care navigation program at these two sites. So the core program components are these. First and foremost, we have a competency-based navigator training program that we use to train cancer survivors and their caregivers to become care navigators. Then we've built a website portal that is used to facilitate both patient and navigator application to participate in the program. It supports patient-navigator communication and the exchange of resources. It also supports the navigator in their management of the peers that they've been assigned to. We have a three-phase-based peer navigator patient-caregiver interaction model, which I'll describe. And then peer navigators are also supported by a strong and integrated supervision and support structure that involves a social worker with triage support to a psychologist. And this includes one-on-one support with peer navigators as well as monthly debriefing sessions that are very similar to rounds or case discussions where peer navigators discuss their experiences and discuss strategies forward. We also have a facilitated online forum that peer navigators can participate in to exchange information and support, as well as guidelines for accessing professional support, and that includes both urgent and non-urgent, medical and psychosocial. And lastly, we have the professional management structure, which I've described. So the program flow is such that essentially a navigator applies, then they're screened, and then if they pass that, they go through a 6-week training program that's online and in person. And then once they complete that, they then create a profile on our TrueNTH website portal. Once that is completed, then we then start recruiting patients and caregivers to participate. So patients and caregivers then apply online, create a profile, which basically is required in order to connect them with a peer navigator. They indicate their matching preferences. So these are the characteristics that they feel are important to them in terms of who they're looking for in a peer supporter. The system then, through the matching algorithm, generates some matches, and then they choose their match, and then they become a dyad. Then there's now sort of a supportive relationship ensues. The navigator initiates contact, and they follow this 3-phase interaction model to provide support and assist and guide and mentor that individual through the journey until their needs have been met or the duration of the support relationship. With respect to who these navigators are, in terms of inclusion-exclusion criteria, we spent a lot of time thinking about this and essentially came to the conclusion, really guided by our clinical team, that it was important for people to have been diagnosed at least 2 years ago and have completed treatment at least 1 year ago, so that individuals had the opportunity to process and experience their own experiences and put them in a better position to be able to focus on someone else's experiences and needs. This includes anyone with a range of different treatment experiences with prostate cancer. So for prostate cancer, that could mean someone who's 1 year post-treatment from radical prostatectomy, external beam radiation, brachytherapy, adjuvant ADT, or a combination, or has at least been on active surveillance for 1 year, as I'm sure you're all aware, and with prostate cancer have a number of different treatment options that they may be suitable for them. And if with respect to ADT, they must be on ADT for at least 1 year. And comfortable using the internet communication technology. Exclusions are a recent recurrence or recently started new treatment. So the navigator screening process is based on procedures developed by the BC Cancer Agency's Lay Navigator Program and Healing Beyond the Body program here at Princess Margaret Cancer Center. And it involves an online application If they meet the eligibility criteria, they then participate in a telephone call where we assess their interest and suitability further. And then if they pass that, they then move on to an in-person screening interview where we use a standardized screening guide that includes the prompts for looking for red flags that may suggest that the individual is not suitable for this particular role. And we do a lot of role-playing through that interview to get a sense of how they would handle certain situations. And after they move through that, they are then invited to participate in the training program. So the training program, as I was saying, is a blended online in-person training program. It was rigorously developed and based on 2 exemplar training programs that we were able to, that we found, the top ones that we found, and that is the BC Cancer Agency's Lay Navigation Program, as well as the George Washington University's Patient Navigation Program. Now, the patient navigation model in the U.S. is quite different in that there are fully employed FTE positions for patient navigators. And we saw a lot of excellent elements in both of these, which we use to merge and create this program tailored to prostate cancer. We also went through a process of validating both the competencies, which include 47 different competencies across 6 core domains, that we wanted the peer navigators to develop to become effective peer navigators. We've validated those. We then matched those competencies to content and developed new content as needed. And patients and caregivers were involved in reviewing and approving all of the content as well. So it includes 8 online modules delivered over the course of 6 weeks. These are the different curriculum units. And it's super interactive and collaborative learning. That's really sort of our model of learning, which means that there are exercises, there are polls, there are role plays, and there's weekly facilitated discussion that they're required to participate in. So what are these competencies? This is the sort of summary of the competencies. There are in fact 47 of them, but there are these 6 core domains. And as I said, it was really sort of built upon the 2 sort of exemplar programs that we identified and then tailored to this particular context. Navigators are taught a 3-phase interaction model that is very problem-based and oriented, where they focus on assessing needs and assessing barriers to getting those needs met, and clarifying understanding of needs and preferences for how those needs could be met and building that relationship. Phase 2 is offering support, sharing resources and connecting people to resources and information that may be suitable, and through that process, helping them to overcome barriers to accessing those supports and resources. And the 3rd phase is closure, so offering additional support only as needed. The role of the peer navigator is not to take over, but rather to enable and facilitate the individual to build the knowledge, capacity, and skills to have their needs met as they go through the process. We also teach our peer navigators to consider the whole person, and we draw on the constellation of needs that was really well articulated in a CPAC cancer journey toolkit. And using this figure, you can see that we really need not only the individual factors that influence one's experiences of health and being well, we're also talking about those larger structural factors that many people have very limited, have no control over in many cases. And the goal here is to really have a fuller understanding of those factors that are those systemic factors, those systemic barriers to access to health and wellness that prevent people, that basically determine their health. These are really the social determinants of health, and that create barriers to accessing health information and support. And while it may seem overwhelming to think of how to consider all of this, we go through a number of case scenarios and worksheets where we have sample individuals, and we, through the training program, our peer navigators would work through and try to identify what people's needs are, and then what some of the systemic barriers they may need to consider that may be different from their own experiences that this individual may have. And so this is an example of the online module. We used a Moodle open source platform, and the first session was in person, the last session was in person, but all of the units were online. And then we had role plays either through telephone or in person as needed. So what I'm going to do is take you through what it looks like to go through, at least from the website perspective, the whole platform. Then I'm going to come back to the training program and actually tell you a little bit more of the great cohort of peer navigators that we've recruited and trained in the results from the training program. So this is there are two different interfaces to the portal. The first is the navigator view. So this is where people who are interested in becoming navigators can apply to become a navigator. Once they complete their profile, they're then assigned a patient. They're required to log check-ins using a structured report, similar to how any professional would record their interactions with a patient. And then the platform offers them a dashboard which they can use to manage and interact with their assigned patients or caregivers. So for patients, again, similarly, either a patient or caregiver can apply. They have to indicate some characteristics about, they have to indicate some information about their own experiences as well as their matching preferences. Their matching preferences, they also have to indicate the level of importance of that matching characteristic so that we can generate a weighted algorithm that aligns with that. Then they're offered a series of potential navigators who may be available, and then they can choose that navigator to work with. And then they can use the platform to communicate with their navigator, or they don't have to. They can communicate, receive support from their navigator through telephone or in person, and arrange a variety of different ways to exchange and obtain support. So that's a quick and fast overview of the overall program in terms of the website. And so now I really want to dive in and tell you a little bit more about the Peer Navigator Training Program. So one of the first things that I'm super pleased to report is that we were very pleased to receive the Innovation and Education Award from the Princess Margaret Cancer Center for this training program. I want to pat ourselves on the back a little bit before I move forward. What I want to talk about is the evaluation of this training program. So we used an explanatory mixed method study design. We were informed by Kirkpatrick's framework for evaluating training programs. It's a pretty established framework developed by Don Kirkpatrick in the 1950s for evaluating training programs. And we really drew and focused on, it's a 4-level framework, focusing on how one reacts to a training program with respect to satisfaction. Level 2 really analyzes the learning that they achieved as a result of the program. Level 3 is really looking at the behavior in terms of can they apply those learnings in practice. And then level 4 is trying to look at how the training program has a sort of positive impact to the organizational or business level. So we really focus on reaction learning, and then I would suggest that we actually focus on behavior as well, looking at least self-efficacy to perform behaviors. So we also draw on Bandura's self-efficacy theory. And our methods include that eligibility application, the pre-training program questionnaire. We have computer log files to study and assess how participants interacted with the training program, a post-training program questionnaire, and then post-training program focus groups. So who did we recruit? Super pleased to say that we had a lot of interest in people becoming peer navigators. Within a 2-month period, and I can speak specifically in Toronto and Vancouver, we were able to recruit 36 people who wanted to be peer navigators, which is a really great response rate in a short period of time. Of these 36 individuals, we accepted, consented 29. People were ineligible either because they had personal health issues, or personal health issues, or they didn't pass through the screening process, were deemed to be not suitable for the role for various reasons. Of the 29 that were accepted and consented, 19 were in Ontario and 10 were in BC. Through the training program, 2 people withdrew for personal, actually 2 for health issues and 1 for personal issues. And so the final trained sample is 26. So we trained 26 men and their caregivers to be peer navigators, and that includes 22 patients and 4 caregivers. I would also say it was really interesting going through this process to learn how to recruit individuals for this purpose. And we started, I would say, promoting it about a year before, where we started to attend fundraising events or public talks where we promoted the program and said, we're looking for navigators. If you're interested, let us know. We'll put your name on the list and contact you when we're at that time point. And we found that what was really one of the most effective was the public talks, recruiting from earlier studies, referrals from clinical champions, as well as members of our patient advisory committee. So who are these navigators? The navigators are on average 66 years of age, range from 54 to 84. The sex of the female, the caregivers, the partners or spouses are 4 of 5 are female. Relationship status, the majority are partnered. With respect to sexual orientation, the majority are heterosexual. With respect to ethnic background, we've got some diversity here, with majority being Caucasian. However, we have individuals from an Afro-Caribbean background, South Asian, Southeast Asian, Asian, and Eastern European origin. With respect to education completed, predominantly university educated, and employment status is almost split, which was actually great to see. We were expecting potentially more people retired wanting to participate, but to have 12 employed, many of whom are fully employed, participating was really great for us to see, because we wanted to understand whether or not this role was compatible with a full-time job. And it really did attract people with a range of different professional backgrounds, which I also wanted to demonstrate and stress that this is not, people who are interested in doing this are not only individuals who are in those supporting professions. In fact, we've got a real range of professions of individuals participating. With respect to disease and health status, majority, and this is referring to, obviously we've got 22 patients and the 4 caregivers, so we're referring to the disease status of the caregiver's spouse or partner, right? So in that case, so majority were 5 years post-diagnosis. Majority had localized or locally advanced prostate cancer, so we've got 3 with metastatic disease. In terms of treatments received, this is pretty representative of the sort of pattern and incidence of treatment types across prostate, being the majority being radical prostatectomy, some with external beam radiation, some with experience with active surveillance, ADT, and we have some with brachytherapy as well. With respect to their sort of baseline levels of anxiety and depression, everyone was essentially as expected to, or borderline a little bit, but that wasn't a concern sort of moving forward at all. In terms of cancer worry, we also wanted to keep track of that, thinking that maybe this could have influenced cancer worry moving forward. And majority of patients, on average, were low cancer worry, as well as, whereas I would say 50, well, in this case, 50% of the caregivers actually had high cancer worry. So that was an interesting finding that you have to watch. And in terms of perceived social support, this was a sample that had very high perceptions of social support coming into it. What this figure on the left is showing you is where people are at in their cancer journey currently. And you may be confused with the deceased, and that is deceased are with respect to the caregivers. So some caregivers are participating where their loved one or partner is deceased. So that's what that means. Oops, this moves so fast. Sorry about that. So in terms of internet use and competence, we also assess that because this is a web-based program. And what we learned is that the majority of the individuals who volunteered to become peer navigators are competent. We did require them to be comfortable, competent using the internet. They are daily internet users. And interestingly, the majority have actually used an online forum, may not have posted in it, but certainly read messages posted in an online forum. This is important because our blended online in-person training program includes an online forum, and the platform itself includes an online forum. This is one of our strategies to ensure that the peer navigators develop a sense of community and mutual sense of support amongst each other as well. 19 of the 28 actually had participated in an online course, which was also very interesting for us. Average age being 66, we were unsure whether or not these individuals, the majority of these individuals would actually have participated in an online course. So with respect to why people volunteered to participate, thematic qualitative analysis revealed that, essentially most everyone volunteered because they wanted to support others. Aside from that, it really sort of fell into three core reasons. The feeling that they really wanted to fill a gap, that this type of support wasn't available, or they had difficulty finding it when they were going through the experience, because they were able to connect with useful support and hence wanted to pay it forward and offer it to someone else. And then interestingly, because they felt that they offered a particular expertise, such as my technical background along with my interpersonal skills, I feel will allow me to assist new patients and caregivers on their journey. So that was interesting that people were also thoughtful of their own personal characteristics and strengths. With respect to how many people had experience with peer support, 22 out of 28 had received peer support from others, and a similar number had actually provided peer support to others. So some peer navigators are in fact members of existing prostate cancer support groups and facilitate those support groups as well. While as other people have never had that opportunity, have never formally provided peer support to anyone. So we do have a range. And so what I wanted to do is show you an example, hopefully on those who are connecting remotely. You'll be able to see this video that I'm about to run. And if you don't, I'm happy to connect you with it later.
Well, I would say that when you go through this process, when you first receive a diagnosis, a couple of things happen. First of all, you feel the weight of it on you as an individual, and you also feel the extension of that diagnosis to your partner, to your family. And I think almost inevitably people would look for support, for someone to be there to help them. In my case, I had a close friend who had gone through the whole process of diagnosis and treatment about 4 years beforehand, and I really leaned on him quite a bit, and I found that extremely valuable because his advice, his almost, you could call it wisdom, based on his experience, was very comforting and reassuring. So having had that experience, I thought when I had the time, when my life made it possible for me, I would like to volunteer to try to reach out to someone else who is in my position. It can be a very lonely experience.
So that is one of our peer navigators, and he explained his motivations for participating there. So I wanted to give you a sense of what their engagement with the course was. It's one thing to say we ran this training program and we've got these great results. Another thing to actually say, well, actually people participated in all the activities and gained from them. So we had high engagement and high participation. People posted on average 2 to 3 posts per week, and everyone completed all activities. And some weeks were pretty heavy, as you'll see from the qualitative findings. And what we noticed is that there was, originally people were responding to the facilitators the most, but over time and through encouragement, they started to respond to each other in the online forum, which is a great sign of collaborative learning. And that's what you see in, unfortunately, I'm only showing you some results from Toronto here, but you can see the increasing participation. This is actually the greatest one to look at here. Percentage of Ontario navigators forum interactions. So you see in units 1 and 2, only 27% are talking amongst each other as opposed to directly to as opposed to only responding to the facilitator. And then that increases to 40 and 47% by unit 5. So what were their overall impressions of the training program? We looked at both acceptability and effectiveness. And what we learned is satisfaction was high. The mean satisfaction across 9 items was 9.4 out of 10. with a small standard deviation. We also looked at usability of the platform, and this is out of the possible 100, so a little bit lower usability, and we certainly learned from our qualitative interviews and rather focus groups what some of the challenges were. I'm including this, even though it does demonstrate sort of a bit of ceiling effects here, and that everyone really liked all aspects of the program, and we're really sort of in that 9 to 10 point range with respect to average satisfaction scores. But there is, within that 9 to 10 point range, a little bit of granularity that one can look at, but again, not a lot that one can draw from that, which is why this mixed method aspect of this study design is so important. It's really through the qualitative work we really understood what they really liked, what they didn't like, and room for improvement. So with respect to the qualitative findings, things that participants valued included the flexibility of the online learning, and I'm going to read some of these quotes for you here. So, well, I'm retired, and it's not like I work all day and then have to do it at night, but you could go through a few pages and kind of, think about it and do something else and come back as your schedule permitted, and that part of it was nice. They also, really valued the in-person relationship building, face-to-face time, as well as the interactive practice-based learning in the form of role play, which this particular quote emphasizes. I would have liked more face-to-face time, and I would have liked more role playing, because it's the only way to really exercise what you've learned, and it's the only really way to test that you've actually learned it. There were also areas for improvement that were identified. While overall people were really impressed and satisfied with the comprehensiveness of the content, they did acknowledge or identify that there was a need for more tailored and targeted content on caregivers' needs and experiences. They also requested more practical content on health information technology and how to find credible resources online. And so after we rolled out the training program to 3 cohorts, I should have mentioned peer navigators, 1 in Toronto and 2 in Vancouver. And so this is sort of an iterative process where we learned this. And so after learning this, we improved these 2 particular components, particularly the e-health component, and enhanced the e-health learning to make it more practical. And also wanted us to distribute the workload a little bit more evenly. Some units were heavier than others. One person was describing in terms of its intensiveness. It was a lot more intensive than I ever imagined would be. Not that I don't think that's a negative thing. I think it's really important that you have that depth of knowledge going forward. So with respect to effectiveness, we essentially looked at 3 different things. We looked at knowledge gained, we looked at self-efficacy to perform competencies, and we looked at e-health literacy. And this was using pre-post questionnaires. And so we found that knowledge improved. There was a statistical significant improvement in knowledge across all 19 items, and the average score improved, well, more than a full point from around, I don't have that average in front of me right here, but it's looking a bit below 7.5 to a little bit over 9 there. And we found particularly larger jumps in areas of understanding the role, understanding local and national resources, understanding barriers to care and how to help people overcome those barriers to care, and protecting information technology, rather using information technology effectively and protecting privacy on the internet. We also demonstrated effectiveness in terms of self-efficacy to perform these competencies. And this graph demonstrates the increased pre-post scores in the 6 core domains that comprise these 47 competencies, and all of them were significant in terms of showing significant increases in people's confidence to perform the required competencies for the role. And lastly, we also demonstrated an increase in e-health literacy. So e-health literacy is a concept of literacy that was introduced by Cameron Norman and Harvey Skinner, and it's really defined as the ability to seek, find, understand, appraise health information from electronic sources to inform one's health and healthcare decision making. What we demonstrated, a pretty nice increase again, in overall e-HEALS is a short form term for the e-health literacy scale. And with respect to qualitative findings, again, we wanted to dive in and really understand what the effects were from people's perceived perspectives. And we identified 6 overall themes. The first is strengthened awareness and confidence in performing the peer navigator role and understanding the boundaries of that role and understanding the difference of what medical information is and knowing not to provide medical information, knowing what expertise and information, the boundaries of the expertise information that they were providing. Peer mentorship. We actually witnessed a lot of peer mentorship occurring through the training program, where individuals would describe maybe anxiety or apprehension about certain aspects of their peer navigator role, and we'd see other peer navigators step in to say, well, I saw you talk about that, or I observed you doing that, and I thought you were really good at it. So if you just do it in that way, I'm sure it'll be fine. Transferable skills and skills for life. This was really enhanced. This was really emphasized, this notion of even just the knowledge one gained helped them as prostate cancer patients going through their journey. In particular, people really appreciated and felt that they learned a lot from empathetic listening, and I really like this particular quote. What I got out of the course was the empathetic listening, because it's easy to hand out advice, where it's more difficult, I think, to try and grasp the whole situation, where the person is coming from before you really start talking. The other thing is that we noticed that people really developed a sense of ownership in the program and wanted it to fly, feeling of really being invested in the program's success, which is a good and bad thing, I would say. For example, we are hoping we're going to do our best to make the program fly. You know, that's our hope, that it works. If it seems to help people, that would be the genuine outcome that could propel this program forward. At the same time, we taught a lot of material, and a lot of people did mention this was pretty intensive. And many people said that they appreciated that because it had some gravitas, as one person said, or provided oomph to it, added credibility to the program. At the same time, once it came time to being matched with patients, people were expressed a bit of fear that, am I going to remember everything? If you don't use it, you lose it, sort of thing. So there was concern about how prepared one can actually feel, and the concern that there may be attrition in their knowledge by the time they're matched. And so I have one more video to play, and then basically summarize and give you a heads up on next steps. So I'm going to try to play this video again. I hope you were able to see the last one. This is another great one.
The training is the unique part of this program, because with training, it allows people to be aware of what the role should be. In other situations, we may have people who are buddies, but they're not really dealing with the needs of the individuals who come to them. They're more dealing with themselves and sharing their stories. Not that there's anything wrong with that, but when somebody comes to you, it's because they have a specific need. So the uniqueness in this program is the training.
So in summary, summarize the results from this phase 1, the implementation evaluation of this training program. We've demonstrated the acceptability and effectiveness of what's called a blended online in-person training program to train men with prostate cancer and their partners, caregivers, to become peer navigators. We recruited 36 navigator applicants in less than 2 months, which is a really great and a rapid recruitment rate that really demonstrates a lot of interest. We delivered the training program to 3 cohorts of learners in 2 Canadian cities. All peer navigators completed all program activities, and there was a retention rate of about 90%. In terms of, not retention of knowledge, retention of peer navigators in the program. There were some people that had to drop out, as I explained to people, due to personal and health issues. And we demonstrated statistically significant increases in all learning outcomes, and these included perceived knowledge and understanding of learning objectives, self-efficacy to perform competencies of the peer navigator role, and then e-health literacy. And lastly, we were very fortunate to receive the Princess Margaret Innovation Education Award for this particular training program. So in terms of next steps, now we're matching. So we're actively running this pilot feasibility study where we're matching these trained peer navigators from Toronto and Vancouver with patients and caregivers who are looking for support. The overall purpose of this pilot feasibility study is really to assess the feasibility of the methods and procedures of the overall program and to explore possible effects that could be explored in a future trial. So the specific objectives are to assess the feasibility in terms of your traditional feasibility outcomes such as recruitment rate, retention rate, adherence, implementation fidelity, and practicality. to assess acceptability in terms of people's reaction to the program, the usability of the platform, and their perceived benefits. And lastly, to explore possible effects on patients and caregivers as well as navigators. And that's it. I did a whirlwind overview of a lot of work that a lot of people contributed to, and I'm happy to take any questions now.